understanding of this condition, then maybe it'll help you with your decision making. Maybe you won't call that consult. You say just, this thing is hopeless. Let's not waste time. So, having said that, I thought that here my outline for this talk is first to give you some sort of a historic introduction, then the definition, what is the definition of hepatorenal syndrome, incidence, its pathophysiology, precipitating factors, the differential diagnosis.
Yeah. Can you have your cell phone on you?
Yeah.
Turn it off.
Okay. Prognosis and then treatment. And in the treatment, I've tried to get as scientific as I can to find out treatments, that have a scientific basis, okay, for the condition. So let's start with a case. This is a true case that many of us saw at University Hospital. A 41-year-old woman with long-standing history of alcohol, tobacco, and drug abuse was admitted to University Health Shreveport, complaining of abdominal distension, jaundice, and a recent history of decreased urine output. 11 months ago, a diagnosis of alcoholic hepatitis, ascites, was made, and she was placed on spironolactone and furosemide. 5 months prior to the admission, her bilirubin was 2.7 and her creatinine was normal at 0.8. But she could not stop. I mean, she kept drinking 750 mLs of vodka a day. I don't know whether it was Grey Goose or not, but she drank a lot. And an occasional ibuprofen that she was taking for symptomatic ovarian cysts. But she was alert and oriented. She didn't have asterexis. She looked relatively well, other than her icterus, the ascites, okay, and she had no pedal edema, no stigmata of liver disease. Her blood pressure was low, 90/60. But striking, her creatinine is 9, BUN is low. You know why? Because when you have liver disease, you can't synthesize BUN. She had hyponatremia, coagulopathy, INR was 2.8, a high white count, anemia, a bilirubin of 23, an albumin of 1.6, and a normal ALT. Her AST was slightly elevated. Okay, so she had all these clinical labs that indicate that her liver was not doing a good job. She couldn't synthesize coagulation proteins, her albumin was low. And now, at this point, we'll leave you with this case and we come back to it as we go along. So, this syndrome was first described by Frerichs and Flint. They sound as a nice name, like two guys from the same team. And they noted an association between advanced liver disease and oliguric renal failure, and when they looked at the autopsies, they found there was no histologic change in the kidneys. And then later on, 100 years later, Sheila Sherlock, a very great physician in London at a time when there were hardly any women physicians. She had a liver unit in London, and she came to the conclusion that this syndrome, hepatorenal syndrome, it results from peripheral vasodilatation. And she actually gave norepinephrine to her patients, and the urine output picked up, but the patients still did not recover. Okay. So that was her contribution. She has, and so she was named, she was given the name Dame Sheila Sherlock, equivalent to Sir. 1969, there's a paper in the New England Journal where they took one kidney from 5 patients, and both kidneys from a 6th patient dying of hepatorenal syndrome, because they were suspicious that this is a functional problem. And they transplanted them into patients who needed kidneys. And surprisingly, the kidneys worked. So they said, well, these kidneys are not really that damaged. There's a functional process that causes renal failure. And then Dr. Starzl, you know, the pioneering surgeon for the liver, he did the opposite. He took 3 patients with hepatorenal syndrome and he transplanted livers into them. And lo and behold, the hepatorenal syndrome resolved and the patients recovered kidney function. So further pushing this concept that the kidneys are just functionally, you know, not working. There's a functional problem. It's not so much structural. And then Murray Epstein did some elegant studies. I think he was at the University of Miami. He used a gas, xenon, a radioactive gas, using xenon washout technique and renal arteriography. He found that the cortex of the kidney, the blood vessels are highly constricted, okay? And that when he looked at those kidneys, when the patients died and looked at them in autopsy, there was no vasoconstriction. All the blood vessels were dilated, okay? And so he gave patients phentolamine, which blocks alpha adrenergic receptors. But in his hands, those patients did not get better. So that's a historic perspective, okay? In 1994, the ascites club, you will think that the ascites club is a bunch of people with ascites, but no. These were people who were experts in liver disease. They convened a meeting in Chicago, and they said, of course, what people have written is, you know, not that it's not accurate, but we need to have some strict guidelines as to what hepatorenal syndrome is. And so they came up with this, that when the serum creatinine in a patient with cirrhosis is greater than 1.5, okay, you can say that this patient has hepatorenal syndrome once you exclude the following. So you exclude, you give IV albumin, you take the patients off diuretics, patient has not received any nephrotoxic drugs, the patient is not in shock, and there is no other evidence of parenchymal renal disease, namely there's no hematuria, there's no proteinuria. And in that setting, when the creatinine is 1.5, you know, you can say that this patient has hepatorenal syndrome. And you know, 1.5 for a cirrhotic, that's probably a GFR of about 20, 25. Because they make very little, they have a very poor muscle mass. So they don't generate that much creatinine. Then they went on further to say that there are 2 subtypes of hepatorenal syndrome. The type that we usually see and we are consulted for is type 1. Type 1 is where things are progressing rapidly, okay? The patient's creatinine is there's doubling of the initial serum creatinine to a level greater than 2.5, or a 50% reduction in the creatinine clearance to a level less than 20 ml per minute in less than 2 weeks. So there's a marked drop in renal function, and usually you can identify a precipitating factor. And these patients are very sick. There's multi-organ dysfunction affecting the heart, adrenals, brains, and so on. Then you see the type 2 hepatorenal syndrome with a smoldering, slowly progressive disease where you have a creatinine above 1.5. Okay? It is probably a continuum. You know, you have type 2, and then as liver failure progresses, there's a precipitating factor, and then you find it becomes type 1. Okay? Now, what's the incidence of renal disease in liver disease? Okay? There are all kinds of renal diseases. So this is a retrospective study looking at 423 patients. Okay? And they found that, you notice, a third of patients will respond to IV fluids. So there's a lot of pre-renal disease in patients with cirrhosis. And usually just you give albumin or IV fluids and they respond. Then you have the second septic or hemorrhagic shock. Typically that gives rise to ATM. and that will not respond to IV fluids. Then nephrotoxins, chronic GN in 6% of cases, obstructive uropathy, there was only one patient, and hepatorenal syndrome type 2, 20% of patients, and type 1 is 6.6% of patients. And that's sort of the breakdown in that particular report. So what's actually going on? You know, when a patient with cirrhosis presents, especially with the hepatorenal syndrome, this sort of gives you a visual idea. You first see there is a increased, so you have a diseased liver, okay, and the diseased liver is going to create portal hypertension. So there's portal hypertension, and perhaps the diseased liver is releasing substances like vasodilatory substances coming either from the liver or from the gut, such as nitric oxide, carbon monoxide, and so on, that cause splanchnic arterial vasodilatation. So the whole splanchnic circuit is tremendously vasodilated, and that would result in a low effective circulating volume. At this stage of the game, the body compensates, and you retain salt and water, your plasma volume goes up, your cardiac output goes up, and you restore effective circulation, circulating blood volume. There's no ascites at this stage. But as the liver fails and the portal hypertension gets worse, and perhaps there's one theory, you have bacterial translocation at this point, the splanchnic vasodilatation gets even worse, and you actually have now peripheral or systemic vasodilatation. Your blood pressures are now low. And at this point, the heart, which has been compensating with increased cardiac output, okay, it's a hyperdynamic state, starts failing. And there is some research, cardiac research, showing that there's both systolic malfunction and diastolic malfunction of the heart. And that could be from cytokines, from inflammatory products, and so on. Okay? And of course, in the patient who is an alcoholic, they may even have alcoholic cardiomyopathy. So all that combined makes the heart's compensation not adequate, so that the renal vasoconstriction gets worse. So the kidneys are basically responding to inadequate cardiac output. So you have this situation where the splanchnic arterial system is vasodilated, systemic arterial system is vasodilated, but the kidneys are vasoconstricted. Okay?
Why would the kidneys vasoconstrict?
I'll tell you. Right here. The kidneys are not seeing enough perfusion, right? Because at this point, the heart is not able to compensate. And all these factors that cause vasoconstriction are released by the kidney itself. So you have got activation of the renin angiotensin system. You have got activation of the sympathetic nervous system. So you've got lots of norepinephrine. And you have got the activation of the vasopressin system. You've got a lot of ADH circulating. Okay? Almost similar to patients with heart failure. Okay? So it's a similar pathophysiology. And notice in this slide, the patients who have ascites plus renal failure have the highest level of renin, aldo, norepinephrine, and ADH. Okay? So it's like a continuum. You start with a little compensation, then you have ascites, then you have renal failure. Okay? Now, some people have also proposed that the kidney does not put out vasodilatory substances. That means it's like one-sided. You have got all the vasoconstriction, and so the prostaglandin secretion is diminished by the kidney. And that's why these patients are very susceptible to non-steroidals. So if you give a non-steroidal, they go into renal failure quickly. So going back to this theory of this splanchnic arterial vasodilatation, there's one theory that there's translocation of bacteria from the gut. And in this diagram, you see the bacteria leaving the gut, entering the lymphocytes. And then the lymphocytes are releasing pro-inflammatory cytokines such as nitric oxide. And there may be a host of them that we don't measure. And there's overexpression of toll-like receptors, activation of NF-kappa B. And all that results in the splanchnic vasodilatation. So you saw the paradox. Vasodilation there, but the kidney is vasoconstricted. So to prove this hypothesis, this group published a paper in Annals in 2003 where they said, okay, we'll try and clear up bacteria from the gut so that there'll be less bacterial translocation. So they did a double-blind crossover design where they took cirrhotic patients and they gave them norfloxacin for a month and then they gave placebo for a month. And what they found is there was a decrease in plasma endotoxin level, okay? An increase in the mean arterial pressure, an increase in the systemic vascular resistance, but there was no change in renal function. But it gives you some sort of an idea that the endotoxins released from translocation of bacteria have an impact on the mean arterial pressure and the systemic vascular resistance. So, whenever a patient has rapid loss of renal function, you have to look for precipitating factors, I said, for HRS. So one is bacterial infection, like spontaneous bacterial peritonitis. It could be even a pneumonia, it could be a gastrointestinal infection. Large volume paracentesis. If you don't give the patient albumin, you may end up pushing the patient to HRS. GI bleeding, acute alcoholic hepatitis. Okay? All these can lead to worsening of the renal vasoconstriction. You have cardiac dysfunction from cardiomyopathy, sepsis, and the end result is severe renal vasoconstriction and HRS. Okay? So what is the prognosis of HRS? And that if you can't reverse HRS, the prognosis is horrible. So type 1 HRS is as high as 80% in 2 weeks. So that's an extremely high mortality. And only 10% of patients will survive more than 3 months. So think of the patient that I just discussed. When you look at what's going on with her liver and her kidneys, you can predict that she may not make it. And even type 2 HRS, even though the survival is better, it's approximately 6 months. So you're talking about a condition where patients will be dead by the end of that particular year, the year you're seeing them. Okay? Another way to look at the extent of liver disease is to use the MELD score. The MELD score is used by transplant surgeons, okay? And the score is calculated based on the serum creatinine, the requirement for dialysis, the bilirubin level, and the coagulation INR. Okay? If you get a score more than 20, you won't survive for more than 1 month. So that tells the surgeon, we have to take this patient for transplant. They changed the number on the waiting list. The patient moves into another category. MELD score less than 20, survive 8 months. So when you think about this condition, whether it's 1 or 2, survival is very poor. Now, nevertheless, when we see patients with renal failure, we have to go through an exercise of finding out, what is the cause of. Besides hepatorenal syndrome, hypovolemia, as I told you, can reverse and improve renal function. Okay? So you can improve renal function. So GI hemorrhage, renal fluid loss from diuretics, diarrhea from lactulose, or an infection, Then you're checking for proteinuria, hematuria, and checking for any medications the patient could have taken. Our patient had taken non-steroidals. It's difficult to separate HRS from ATN. Okay, a lot of people make a lot of noise about that, that if HR is hopeless, but ATN, maybe there's some hope. There is no hope even if it is ATN, because that tips the patient into an advanced renal disease. And it's difficult to make the diagnosis. You find granular CAS, and I've shown you an example of a coarse granular CAS, both in HRS and in ATN. Though they say that in ATN you see renal tubular epithelial cells as shown here. All right. So you have a granular cast epithelial cell. And the FeNA typically in HRS is less than 1%, and in ATN is more than 1%. But notice the FeNA was not used in the diagnosis of HRS because of this difficulty. They just went with the creatinine, okay, for HRS1 and HRS2. And you will find that the FeNA changes. If the patient is on diuretics, you may have HRS and a high urine sodium. On the other hand, if you, sometimes patients who are septic and who have received radio contrast may have a low FeNA and still have ATN. So let's go back to our case. The urinalysis showed protein, it showed red cells, it showed lots of white cells, and I think they did do a right stain, and there were no eosinophils. There was lots of bilirubin, and the urine sodium was high. So this urinalysis could be consistent with ATN, or it could be consistent even with a glomerulonephritis, with proteinuria and red blood cells. Blood and peritoneal fluid cultures were negative. Ultrasound showed a nodular fatty liver. The echo was not too bad, okay? And the EGD showed candidiasis, antral gastritis, and many ulcers without active bleeding. So if I was handling this case, I mean, I would have probably not gone further than that. I would say this patient is really sick, probably not going to live very long, and I would have not embarked on dialysis. But these doctors were very gutsy. So they gave the patient FFP, okay, corrected the INR, and did a kidney biopsy, okay, to find out the diagnosis. And what they found typically was these casts, okay, that are stained with bile in the lumen of the tubules, as well as intracellular bile. And they did a special stain called the Hall stain, which apparently was staining these tubular casts. So basically the diagnosis here, and if you notice the tubules, there's a lot of tubular damage. So this patient was diagnosed to have bilirubin associated renal failure with a high bilirubin, okay. But as you saw in the MELD score, a high bilirubin is one of the major factors, you know, in the scoring system. A high bilirubin, a normal ALT, a high INR, all favor a very poor prognosis. So at this point, we'll talk about treatment and come back to this case. So when a patient with cirrhosis who has renal failure, especially acute renal, comes in, there are certain general things that you should do for all patients, okay? If the patient is going to get a liver transplant, you're going to have aggressive treatment, move the patient to the ICU. And that happens a lot at Willis-Knighton. We move the patient to the ICU. Get a central venous access, because it's hard sometimes to get lines. And also you can check pressures, CVP. Okay. Stop diuretics. If you have ascites, you're going to tap, and you're going to give albumin if you take more than 5 liters. You're going to check for GI bleed. You're going to send the acidic fluid for cultures and cell counts. You focus on nutrition, but if you give too much protein, you can make these patients encephalopathic. Low salt diet and fluid restriction if the patients have hyponatremia, and if they have lots of ascites and if they have a lot of edema. Avoid, of course, common sense nephrotoxic agents and excessive IV fluids. And you reserve aggressive therapy for patients who you're going to do a liver transplant in, okay? If you feel the patient is a candidate for a liver transplant. So what are these specific therapies? And they're basically 4. The first is pharmacologic treatment, which we typically offer almost all patients with HRS. Next is TIPS, renal replacement therapy, and liver transplantation. So notice that those are even higher, more challenging types of therapies. So all patients are given albumin. Yeah, albumin is like a big thing in HRS. And where does this literature come from? So there was a study from Spain. 7 medical centers in Spain got together and they found 126 patients with HRS, okay? No, not with HRS. 126 patients who had SBP, spontaneous bacterial peritonitis. And they divided them very equally into 2 groups. 63 got cefotaxime, okay, as treatment, and 63 got cefotaxime plus albumin. And they followed them from day 0 to day 9, and you will notice that the ones who got albumin, okay, their renal function, the best way is to look at the serum creatinine, remained actually very stable. But the patients who did not get albumin, there was a worsening in kidney function. Okay? The mean arterial pressures were not different, and when they measured the plasma renal activity, notice the patients who got albumin, the plasma renal activity went down, implying that there was more perfusion to the kidney. You know, the vasoconstriction was less. And when you look at the outcomes, there was an equal response to the antibiotic in both groups. Duration of therapy was no different. Ascites, paracentesis was no different. Hospital stay was no different. But this renal impairment was really the development of HRS. That means that was renal failure that was not responding to therapy. That occurred in 33% of patients who did not get albumin, and only in 10% of patients who got albumin. And further, the in-hospital death was much higher in patients who did not get albumin, and the 33-month death was also higher. So this study was suggested that if you gave albumin or fluid while you were treating SBP, which often leads to worsening of liver function, somehow you improve the renal perfusion, you improve hemodynamics. So is it just the intravascular volume expansion? That's possible. Or is it some special benefit of albumin? So people have even wondered whether albumin, yes sir?
How many of those patients actually had hepatorenal syndrome?
No, these patients did not have hepatorenal syndrome when they came into the hospital. So if you look at their creatinine, it's very similar at day 0. Okay, and there is the p-value is 0.66. But there was worsening of kidney function in those patients who did not get albumin, and this renal impairment, what they mean by renal impairment is irreversible loss of kidney function. I think this would be called hepatorenal syndrome. That developed much more in patients who did not get albumin. And from this study, you know, all patients who you suspect of HRS should get at least albumin, you know, before, plus a vasoconstrictor, but albumin definitely, okay? And if they are pre-renal, something just, they will respond, and creatinine will come down. You don't have to do anything more.
Has this been replicated in patients who actually have hepatorenal syndrome, or is it just extrapolated from this study?
Most of these are, no, after this, most of the patients who have had hepatorenal syndrome have got albumin.
Okay, so
you know, so it's a good way also to ruling out pre-renal. If it's not hepatorenal, just pre-renal from volume depletion, you give the albumin, and if you get a response, I don't think you need to go further. And that's why in that study, that retrospective study of 423 patients, there were a substantial, like 30% of patients responded just to volume repletion. It doesn't have to be albumin. It could be saline too, you know. So, but this is like the paper from which. Then there was a study of Terlipressin. Now, Terlipressin is a 12 amino acid synthetic analog of lysine vasopressin. Now, remember, the vasopressin levels are already high in these patients. So they said if we can give the synthetic analog and somehow decrease the vasodilatation, the splanchnic and the peripheral vasodilatation, will the vasoconstriction in the kidneys decrease? So this was a big study. It was 35 centers in the US. It included Russia, centers in Russia, in Germany, okay? And basically the study was 14 days long, okay? And it was quite a strict study. you had to demonstrate a decrease in the creatinine below 1.5, okay, for you to say that there was success. Now, if you look at it, HRS reversal was seen in much greater, if you notice, in the patients who received Terlipressin. And the Terlipressin was given for the first 3 days, and if there was no response on the 4th day, it was doubled. Okay, and that's why when you look at the treatment outcomes, they have divided them into patients who received more than 3 days of treatment. And notice the mean change in the serum creatinine, actually in the placebo, it's worsening, right? And in the Terlipressin, it improved. And if you look at patients, quite a number of patients, almost double the number of patients who received Terlipressin, had an improvement in kidney function and got out of HRS1. So you would say, wonderful, such a wonderful drug, we should be using it. But unfortunately, it's not available in the United States. It's only available in Canada. So you'll have to take your patients to Canada if you want to get them this therapy. Okay? So the next one is the therapy that we use here, right? This is a study, but the numbers are very small. Terlipressin study had 63 in each arm. Here you have 8 patients with HRS1. In group A, they got dopamine, low dose dopamine, 2 to 3 mics to vasodilate the kidney. Okay? And group B were patients with HRS1 who got Midodrine plus Octreotide. So what is the concepts behind this? Midodrine is a vasoconstrictor. So you're trying to vasoconstrict this splanchnic and Octreotide is an inhibitor of substances that vasodilate. Inhibitor of substances that are vasodilators, okay, like glucagon and so on. So they said if we combine these two, okay, let's see whether it makes a difference. Now notice, by day 10, most of the patients in group A are dead because by day 20, there are no labs here. Okay, so most of them are dead. But if you notice group B, there is a significant improvement in arterial pressure, the heart rate drops, okay, renal plasma flow goes up, GFR goes up, urine volume picks up, urine sodium excretion goes up, creatinine has come down, okay, at day 10, and serum sodium has improved. So quite an impressive, impact in these patients with HRS. But again, the numbers are so small. And when they measured the vasoconstrictors, the renin activity, it has decreased. Aldosterone decreased. ADH decreased. Now, they measured nitric oxide, but we don't know why. The nitric oxide levels actually came down too. So the vasodilators, and you have glucagon levels came down. Okay? So this study, but when they did a survival curve, notice by 10 days they lost most of the patients. Most of the patients who did not get Midodrine and Octreotide, and at day 30, I think they lost 1 patient. So about 7 patients were living. You notice, so the numbers are small, but this is where we are getting our treatment options. Okay, and then finally, among the vasoconstrictors, there's a study using norepinephrine. This study didn't have a control arm. They took 12 cirrhotic patients with type 1 HRS. You have to move the patient to the ICU, and they gave them norepinephrine to raise their mean arterial pressure by 10 to 15 millimeters of mercury. And again, there was an improvement in creatinine from 2.6 to 1.6 on day 10, okay, and increase in urine output. And in this study, the mean arterial pressure went up, and notice the plasma renin activity and the aldosterone levels, they actually came down significantly. Okay. So to summarize your pharmacologic management, you want to offer albumin, and it's given here, intravenous albumin in a dose of 1 gram per kilogram of body weight on day 1, and then followed that by 20 to 40 grams per day, and with the vasoconstrictor. And we can choose Midodrine 7.5 milligrams given 3 times a day, and you can increase it if necessary, and you can use Octreotide, and the doses are given. And finally, if your patient in the ICU, you can use Levofed or norepinephrine. Now let's shift to TIPS. TIPS stands for Transjugular Intrahepatic Portosystemic Shunt. Okay. We do a lot of this at Willis-Knighton because we have a transplant service. Okay. And what does TIPS basically do? It forms a channel between the portal vein and the hepatic veins that are opening into the inferior vena cava. So you are bypassing the liver. So think about it, by bypassing the liver, you are decreasing portal pressures. You will decrease variceal bleeding. You will decrease ascites. Okay? However, you will increase encephalopathy because the blood is not going through the liver. You will increase intravascular volume, and you can put patients into fluid overload. Okay? So there are you can cause DIC. So there are downsides to doing it. But if you have a patient who is waiting for a liver and he's coming frequently for acidic taps, or he's having GI bleeding then you should consider this. So they took 7 patients, okay, and they did the TIPS procedure. And it took almost a month. Notice at 7 days the creatinine was still up. It took almost a month for the creatinine to come down, but it never reached normal. It's like going from HRS 1, you could say, well, are they in HRS 2? All right. And the urine sodium never really picked up. It's still below 10. Okay. But notice an improvement in the PRA, an improvement in the ALDO, and the improvement in the norepinephrine. So this is not, it doesn't cure, there's nothing that cures HRS, it just delays the progression of renal failure. Okay, buying enough time for you to get a liver transplant. So now we come to this issue of renal replacement therapy. Given such a bad prognosis, should you even embark on renal replacement therapy in these patients? Okay. My take on it is, certainly you want to use it if your patient is waiting for a liver transplant. Or you have a patient who is not an alcoholic. He had a reaction to a drug. We had a soldier from Barksdale who had a problem with Bactrim. He had got fulminant hepatic failure from Bactrim, and we transferred him to Willis-Knighton. You do all this to keep him alive so that he got a liver transplant and did well. But the majority of patients, I don't think you can say that. Especially the patient who you start renal replacement therapy and nothing is improving. The patient is anuric. That patient is going to have a very, very hard time in the outpatient dialysis setting, because these patients get GI bleeding, worsening of the ascites, encephalopathy. So you have not improved the quality of their life. Okay. So it is a controversial thing. In untreated patients who have type 1 HRS and are not candidates for liver transplant. So a patient who has been drinking, like this lady, shows up, see, that her last drink was yesterday, is not a candidate for liver transplant because they have to be alcohol free for 6 months. They can't live that long, So you'll have to have a patient, if you're going to ask a transplant surgeon to come by, you have to have a patient who is not an alcoholic. Okay. Has anyone heard of Mars? There is a system called Mars. Men are like what? Women are like Venus, and it has nothing to do with that. Okay. This Mars is a system, is called molecular adsorbent recirculating system. The theory behind this is that there are albumin-bound toxins, okay, and one of them is bilirubin. And if you have a membrane with albumin on this side, and you can regenerate the albumin, get this, then you can pull all these albumin-bound toxins out of the body. And it's sort of you have heard of liver dialysis? So that's the concept, okay? It's like liver dialysis. And so in the MARS, it looks like a dialysis circuit here, and then you have another online circuit, and you have a column of charcoal and a column of an ion exchange resin, and then you have bicarbonate on this side. So I'm just assuming that these impurities are going into this, okay? So they're either coming off the column, and the albumin that returns has none of those toxins. They have been cleared, okay? And they are fresh, and they keep pulling. So there was one prospective trial, okay, again small, MARS in 8 patients and hemodialysis in 5 patients. They say hemodialysis because these patients are very sick. They had HRS, and the average bilirubin among these patients was 25. So they're very sick patients. And so the non-MARS group also, they offered dialysis. So they could have dialysis in the non-MARS group, in both groups. And the patients who were on MARS did much better, okay? So the creatinine level in the MARS group dropped compared to the just the dialysis group. Bilirubin, see, dropped. Sodium was better. The prothrombin activity went up. MAP was better. Urine output was not significant. It looks high, but it was not significant. And of course, this was such a sick group. By about 7 to 8 days, they were all dead. The ones who got dialysis. Whereas in the MARS group, you still had almost 60% of patients alive at 7 days. But notice that eventually. So MARS is another type of therapy that can be used to delay. But the definitive therapy for HRS is a liver transplant. Okay. So this study is a very large study. They had 300 patients who got liver transplants in Dallas at Southwestern. Dr. Gonva looked at patients who had HRS versus patients who did not have HRS. And notice here, no HRS, 263 patients. HRS, 31 patients. So no, the HRS patients, of course, had an elevated creatinine, and some of them were probably on dialysis, because very often we have patients on dialysis before they get the liver transplant. But notice post-operatively, the renal function went down even in the no HRS patients, okay? But in the HRS patients, it never recovered to the level that you see in no HRS. So there is a substantial loss of kidney function. Because remember, after a liver transplant, we give them medications like cyclosporin, which are nephrotoxic, okay? So they've already had one hit, the HRS, and then on top of that, we give them. But if you look at these two survival curves, there was no significant difference in survival. Although this curve, this is the HRS curve, looks much worse than the no HRS patients. And in other studies, they have found that patients who had HRS, they had their survival was poor. So having HRS prior to a liver transplant, you don't do as well, okay? But this is the only, I would say, the only therapeutic cure for it. So what happened to our patient? Our patient was started on intravenous fluids and albumin initially, but there was no improvement in the creatinine and the urine output. So the patient was given Midodrine with Octreotide. They did all those things, and over the next 4 days, there was no improvement. Dialysis was initiated. So this is where you have to decide, does this patient really need dialysis? Then they got the biopsy, and they put the patient on prednisone, hoping that the alcoholic hepatitis that she would recover from that, and things would get better. Now, her bilirubin went down to 16, but that I could argue that's just from dialysis, because dialysis removes bilirubin. So it went from 23 to 16, I would say it's from dialysis. Urine output was 500 cc's, and then she was discharged. Now this patient then went to the outpatient unit, because mind you, this patient did not have encephalopathy. She seemed alert and awake, telling you that patients are not all the same. But eventually, she came in with severe GI bleeding. I mean, we were transfusing her almost every day. And eventually a decision was made by the family to move her to hospice, and she passed away 4 months. So this would be something typical for someone who had HRS. So here are my conclusions. Hepatorenal syndrome is a diagnosis of exclusion. Okay. And an accurate diagnosis is often difficult. You have to try to get an accurate diagnosis, but often it's difficult. It carries a horrible prognosis. The pathophysiology involves vasodilatation in the splanchnic and systemic arterial beds and vasoconstriction in the kidney. Pharmacologic treatment should be tried in all patients, and it should include albumin infusion and a vasoconstrictor. TIPS, MARS, and RRT should be reserved for patients who are candidates for liver transplant. Okay. Now I have to thank Eric. Eric in our department, he was kind enough to cover me, because I had to give my talk on in the first week of May, but I had to go for my grandchild's birth, and so I'll end by just showing you Henry Joseph Abreo's picture. Now I'm 10 minutes for questions.
I remember being taught as an internal medicine resident that hepatorenal syndrome was an iatrogenic disease caused by giving diuretics to patients with liver failure. What I'm getting from you is that it can happen even without the iatrogenic.
In fact, there is no literature on diuretics inducing hepatorenal. There's no literature. There's a lot of, speculation. Of course, all these patients are on diuretics. They have ascites, and they have edema. So everyone is on loop diuretic like furosemide and on spironolactone. So I believe it's just progression of their disease. And if it is from a diuretic, if it's not hepatorenal syndrome, when you give the albumin and fluids, the renal function recovers. So there is no evidence in the literature that diuretics cause HRS. Yeah.
Have there been any studies looking at the type of volume replacement as the initial evaluation, comparing albumin versus saline?
No, I could not find any. Thank you.